placement. Our pilot for non-law enforcement transportation, the RFP for that just closed. So I can't tell you who was chosen yet or what areas were chosen. Remember, it is exactly what it sounds like. It's the ability to transport people in mental health crisis in medical transportation rather than in a police car. And then lastly, we got a pocket of money, $20 million for crisis technology. So this is our bed tracking system, so we know where community psych beds are. Now we have all the crisis centers on, and we also have the psychiatric residential treatment facilities. Those are being onboarded as well. We're also piloting in the East mobile crisis deployment and tracking. So we can, just like the 911 center, we can deploy mobile crisis, track when they get there, and then track the disposition. So we have to be able to have some accountability for response time and also for disposition of the case. We've used some of those dollars to expand telehealth in school. And also we're working with some of those crisis providers in particular on EHR enhancements, electronic health records. So when they respond in crisis, they can actually look, understand medications someone might be on, the treatment provider. We think that will enhance their care delivery as well. This is just a map of those existing and anticipated crisis facilities across the state. I have mentioned before that we do use a formula to determine where we would put these crisis centers, and it really is based on things like high ED boarding or high ED utilization, also just general population demographics. So you see in places that are obviously have lower population density, you won't see as many crisis centers. But those places are very, very important to us. So remember, the crisis system is not just a crisis facility or an urgent care, it's also those crisis response teams. And that will be a focus for us this year, improving the performance of those crisis response teams. We also got money for justice investments. So in the justice space, we're looking at diversion. So people with low-level offenses who need treatment, we'd like to get them into treatment instead of having them go to jail. We're also focused on treatment. So when those folks are diverted, they actually have a treatment program to go to, or when they're re-entering after being incarcerated, they have a treatment program to go to. And we're working on treatment while folks are incarcerated. So Karen Burkes, our Secretary for Health, she and her team have been working on capacity restoration. And as a reminder, capacity restoration gets people the treatment that they need so they can go to court. We're doing it in community settings now in Mecklenburg, soon in Pitt County, hopefully soon in another county. So we are freeing up some of the state inpatient beds, which is really exciting, and people are getting the treatment they need. So we spent about $5 million so far in diverting individuals to care. We're expanding something called law enforcement assisted diversion. We'd like that in as many counties as possible. I'm going to show you a map in a minute. That's just what I said, it's getting people into treatment. We are expanding critical intervention teams. That is really important. It's really trained officers, but also convening of communities of law enforcement in hospitals and behavioral health providers in the LME to make sure that when someone is in crisis, maybe 911 responded, EMT or is there law enforcement, they know the trusted behavioral health person they can call to be able to help transition the case. Again, we're trying to avoid folks getting arrested. And then we're working on a whole suite of training materials for court officials so they actually understand the treatment system and where they can refer people to. $71 million is earmarked for reentry programs. Right now we have 2 statewide reentry programs. We have something called TASK. I'll show you that on the map. And we also have something with each of the LMEs where we have the most complex individuals with often long histories of incarceration and severe mental health issues. It can be really complicated to transition them into the community. So we have expanded that program. It is in all 100 counties. And then we have money set aside as well if we so choose to go down the route of getting folks enrolled in Medicaid prior to release. We want to make sure that Department of Adult Corrections, prisons, and jails can get ready for that. So there's some capacity building there if we choose to use it. And then lastly, we focused on access to treatment. So we have now we're building 5 statewide Forensic Act teams. Those are specific wraparound services for individuals. We've also built up capacity for transitional housing and also employment services. We're also starting some work in the juvenile justice space. In particular, we're working with one of the YDCs to make sure that we have a treatment unit within the actual youth detention center. This is just a map. The kind of the teal color is where we have critical intervention training. So those are those community teams that work together to try to get people diverted to care. The yellow dots are where our new LEAD programs are. Again, we hope to find more of those across the state. And some of the purple counties are where we have both programs. As a reminder, we have TASK, which is a reentry program in all 100 counties of the state. As a reminder too, in order to support some of these, like many of these investments, right, all that crisis services that I told you, we really are appreciative of the historic investment in behavioral health rates. So we were able to dramatically increase a lot of behavioral health services, some of those crisis services that I mentioned, some services of outpatient providers. So again, we're trying to get upstream, we're trying to get a solid workforce, we're trying to get people in treatment, because at the end of the day, if we can do that, we can avoid some of these crisis situations or even legal involvement. Workforce investments. So in workforce, we focused on a couple of key areas. First, we focused on strengthening peers. So peers are a certified workforce. We have certified peers in the state. We really focused on making sure the certification was of high quality, but also that we were getting folks into jobs, and we're already seeing that bear fruit. So our certified peers are actually being employed. They can get reimbursed by Medicaid and other insurers, and they're part of making sure that people have access to services. And they often work in some of our most intense situations, right? So crisis diversion, even in emergency rooms. We've also used some of the dollars to strengthen our direct support professional workforce. We just released about $3 million in incentive payments to incent direct support professionals to come to the job and stay on the job for a certain amount of time. We anticipate the impact to reach 10,000 workers, which is a lot, and we need every single one of them. So more workers staying means more people in services. We're also working with the North Carolina Community College System. We're leaning into their expertise to pilot an advanced certification for direct support professionals. We're trying to make it a career. So kids in high school actually want to be a direct support professional, and there's actually a career trajectory for them in our service delivery system. We're also working with SHEPs to look at our behavioral health workforce in entirety, both our licensed and unlicensed folks, to really do a study of where our major holes are and some ideas for how we can fill those holes. I believe you got a presentation by Office of Rural Health. There's some money set aside for loan forgiveness programs for behavioral health licensed professionals. We will be using those dollars to try to fill some of the critical holes in our service delivery system. And then lastly, I have Deputy Secretary Karen Burkes here. She's going to talk a bit more about DSOF, but $40 million was used for retention bonuses for our state facility staff. Now I'm actually going to turn things over to Deputy Secretary Karen Burkes.
Thank you, Kelly, and good morning. So our state-operated healthcare facilities have invested $20 million towards our electronic health record. Currently, within 12 of our 13 facilities, our medical record is largely paper-based. We have over 200 systems that support other functions within our facilities. So we have named our project Emerge. So we're going to emerge out of the paper into Epic, which will be our core system. We'll have a number of third-party applications. Our system is built. We are testing workflows and testing those third-party applications. We are beginning our readiness assessments this month. Our trainers, who will be training our staff later on this year, they will start their training soon, and then we are targeted to go live in the fall of 2025. This is a huge accomplishment. This is something that we have been wanting at our state facilities for a really long time. This is ultimately going to help us enhance our patient care and improve safety. This will also help us with retention and recruitment efforts. This has been an ask from a lot of our recruiters. They're like, it's hard to recruit staff if you don't have an EHR. We just aren't as competitive. This will also improve our revenue cycle functions, increase opportunities for collaborations, and then we will be the second state to go live. So, and we'll be the second state with behavioral health, but we have a much larger scale than the first state, which was Ohio. And so we are helping to develop that functionality with Epic, which ultimately will impact others who are using Epic in the behavioral health space. So also this will help us in terms of, help us when we are transferring patients, either or receiving patients, even if it's just an outpatient. So we are reducing the amount of paper that we have, and this is exciting. So thank you. I'm going to turn this over to Susan Osborne to talk about. I think I did the wrong one, sorry.
There is. Oh.
Thank you.
Thank you. Good morning. So I'm excited to be here today and share the investments that you all made in the 80 million child welfare and family well-being dollars. So I want to start by saying that we have prioritized these funds, and we had some goals as we looked at this funding and decided how best to use this. And our goals were that we had trauma-informed, evidence-based treatments for our youth and our families, that we were supporting our counties, that we were incentivizing innovation, leaning in on partnerships, and taking action. So that's what drove us through this process. So we had 4 buckets for the 80 million. I'm going to talk about 3 of them and then turn it over to Director Crosbie to finish. The first bucket was our community-based services, and that was 22 million. We had 18 million for emergency placements for children at risk of boarding in DSS offices and boarding in EDs. And our third approach is therapeutic programs in family settings. So I'm going to talk a little bit in depth about those and then turn it back to Kelly, who will talk about the intensive treatment settings. So our North Carolina Division of Social Services had 3 initiatives within this bucket. The first one was our emergency placement fund. We took $5 million and allocated it to our counties in February of 2024 to come up with local solutions to prevent children from spending the night in DSS offices. So we know what that looks like. DSS offices, no beds, no showers, no kitchen, not the place for children. And so in this model, we learned about some best practices that some of our DSSs were doing, like reserving capacity for foster parents on a regular basis for emergencies, paying them even though they didn't have a child in that bed. There are multiple other interventions. There's a model out of Virginia that's enhanced, you pay an enhanced rate to take more complex kids. And so our counties have spent 2 million of the 5 million. 42 counties have used this funding. When we were first given these funds, we were averaging in the mid-30s of kids in a DSS office every Friday. In the mid-30s. Yesterday's data, the average for 2025, 22. So we're making a difference, and this is one intervention. The next intervention that the Department of Social Services has invested in is one of those that leans in on a public-private partnership. This is professional foster parenting. We entered a contract with Crossnor Communities to take their Bridging Families program statewide. This is a program of both the foster parents are employed by the agency, and this is their full-time job. They focus on reunification efforts, and they focus on sibling groups. Leon Levine Foundation out of Charlotte has matched our contributions so that we have a strong public-private partnership to take this initiative statewide. In our pilot program, 89% of the kids that were placed were reunited successfully with an average of 12 months. So this is the timeline we want for permanence for children, and this is an effective intervention. So far to date, 55 children have been served from 21 families with 11 current homes. The model will take Crossnor's model, and they will teach, train, and coach other agencies across the state to offer the program, so that we are in all 7 regions. So they've already begun preliminary conversations with partnering agencies, and that's moving along. The third intervention from our Department of Social Services is enhanced emergency care. This takes existing group care, those homes that have been providing care at the non-treatment level, and enhances them with additional funding so they can take more complex behaviors. This is in the RFP stage, but we're excited. This part of this will be a comprehensive assessment of the child, and then a move to what we hope will be a permanent placement. So those are the 3 interventions that our Department of Social Services is working on. Our Division of Child and Family Wellbeing is working on interventions in our schools, in our communities, at home, and in family settings. So to run quickly through several of these, they have put 18 districts now have either in-person or virtual therapy for children in the school where they can get it. They've put new clinical social workers in school health systems, centers, so that they can get treatment and begin the process of what they need during the school day. They're also implementing peer support model, much like Director Crosbie talked about, but with families who have lived experience to help them navigate help families who are new in this behavioral health crisis to navigate. Respite is another area that we've invested dollars so that we can prevent, Senator Bergen, another move for kids, that we are offering respite to our providers who are doing the more complex kids so that they have regular respite. So that's a big investment. In our communities, we've rolled out 5 evidence-based practices and have more than 400 clinicians trained across the state, with a goal that no matter what your zip code is, you can get the service, closing that rural-urban divide. And we've expanded Child First. Child First was in 29 counties, and we're adding 22 new ones. That's a home visitation program for newborns and children up to 5 where there's been trauma. And then in families, we have invested in intensive alternative family treatment. So that is the highest level of foster care. It's a very therapeutic setting. The family is trained. There's a team wrapped around the child and the family, and the home can only take 1 child. So this is for our more complex behavioral health children. And we've had successes there. We have licensed a new agency. We have re-engaged 10 new homes. We have 8 new intensive alternative family treatment beds. And our goal is to increase the acceptance rate. So those are the programs that have been funded with your $80 million. I'll turn it over to Director Crosbie.
Thank you. Thank you, Deputy Secretary Osborne. And again, this is Kelly Crosbie, and I'm the Director of the Division of Mental Health, Developmental Disabilities, and Substance Use Services. I'm going to finish out the end of the child behavioral health investments, and I hope that you saw this is a full departmental effort. Each of our teams are collaborating together with this pocket of funds, and it's everything from helping children in crisis, trying to avoid entry into DSS if they are, making sure we have therapeutic foster homes, community-based treatments, training for families. And I'm going to talk about the other end of the spectrum, which is children who are in our highest levels of care. Those are called psychiatric residential treatment facilities, or PRTFs. I noticed Senator Bergen is very familiar with these, and so are some other members of this committee. So we are doing a variety of interventions to improve the treatment in those settings with the expected outcomes of A, fewer children actually having to go to those settings. That's the goal of everything that Deputy Secretary Osborne talked about. Second, when they do go, that it's highly effective. It's a safe, therapeutic, highly clinical environment. And the length of stay is actually quite brief. We want it to be brief. We want the children to be discharged safely into the community in the programs that Deputy Secretary Osborne talked about, and that they're not going back to this level of care. So to that end, we have a variety of investments and ongoing work in this space. First, one of the issues we have with children in emergency rooms is that sometimes they are children with the most complex needs and they need specialized care. And these are the children sometimes we see, sometimes older, sometimes children who express their issues in physical aggression. We all know these are children that are very hard to place. Sometimes children that are hard to place have autism and mental health issues, a developmental disability and mental health issues. It can be really hard to find a placement for those children, and so they end up being stuck there. So we're actually working on some specialized services in this state for those two populations that I mentioned and others, but those are our two biggest right now. So we need our own in-state beds with highly specialized treatment for those children. We've already funded something called Environment of Care projects. That's the map that you see before you. Where those circles are is not a mystery. Those are places where our highest level treatment is clustered. You see most of it's actually in the Mecklenburg space. The bigger the circle, the bigger the facility. And so we have funded something called Environment of Care grants to those facilities. Those Environment of Care grants came with the agreement that they would work with us on the clinical interventions I'm about to talk about. So these Environment of Care grants will affect over 400 children, and they are for improvements to the physical and treatment space that the children are in. So place for families to visit, recreational space, sensory spaces. We show children that they matter by giving them clean, well-lighted, family-like environments. So those dollars went out. Plus, again, that obligation that those facilities work with us on two other things. One is intensive staff training. One of the things we never want are things like restrictive interventions or physical interventions for children. So we'll be working with all the facilities on improved staff training, happier staff, well-trained staff, trauma-informed staff, using models that do not escalate situations, but instead make children feel safe and stop having things like restrictive interventions. The second thing, though, which is equally, if not more important, is working with them on the treatment milieus provided in those environments. They have to be evidence-based, they have to involve clinicians, because remember, these kids have lots of trauma, significant issues, and they deserve the highest level of care that we can provide. So those are the things we're working on this year, and a way to measure that quality as well. So we actually know, again, kids are getting better. They're dealing with their trauma. They're able to return to the community, not in 9 months, but in 3 months, in 4 months, and the community is ready to receive them. So that's kind of the final piece of the continuum that we're working on. So that's it, and we are happy, Chairman Reeder, to take any questions if you like, or whatever you say. Sorry, you're the boss.
Let me get that from my wife. Thank you very much for a great work. I know that we made enormous investments over the last budget cycle in this area, and I'm really anxious to see the outcomes for what we've done. So thank you very much, recognizing it's still very much work in progress. So we're going to hold questions. So next up is Luke MacDonald from Fiscal Research.
Thank you, Mr. Chair. Good morning, everyone. My name is Luke MacDonald. I'm with the Fiscal Research Division here at the General Assembly. This morning, my presentation will be on two divisions: the Division of Mental Health, Developmental Disabilities, and Substance Use Services, might just refer to it as DMH or Division of Mental Health, and the Division of State-Operated Healthcare Facilities, or DSOF. These are two separate divisions, have two separate administration structures. From a budget perspective, they're typically budgeted together, and that's why we talk about them together. But they are two different divisions, and as I go through it, I'll try my best to split them out and tell you about the different functions in each of the divisions separately. So a bit of a roadmap of what we'll look at. So first, the authorized budget for the current fiscal year, 24-25, an overview of the Division of Mental Health, an overview of the Division of State-Operated Healthcare Facilities, especially looking at the facilities themselves and at the FTEs that staff those facilities. We'll look briefly at the opioid settlement funds that North Carolina receives, a look at the significant budget actions from the current fiscal biennium, 23-25 in this space, as well as some potential decision points in this space in the upcoming 25-27 fiscal biennium. So first, the current year's budget, and we'll compare this to past spending. You can see the 5 bars here represent the 4 most recent completed fiscal years, so actual spending in those years, as well as the current fiscal year's 24-25 authorized budget on the right. The darker block on the bottom represents the receipts, and the lighter block on the top represents the net general fund appropriation as the 2 components of the budget. And you'll recall that the top number represents total spending, total requirements, and so for the current fiscal year, that's the planned total expenditures. So you can see there is some fluctuation, not quite as much as we would have seen, say, perhaps in Division of Child Development, but were some COVID-19 federal funds that were here that explain some of the variations in the receipts, especially the net general fund appropriations have not fluctuated quite as significantly. But as you just saw in the most recent presentation, there was some significant funding provided on a non-recurring basis from the Medicaid Temporary Savings Fund, and that explains a lot of the increase in the current fiscal year and last fiscal year in the receipt space. Is not all of those dollars went through the Division of Mental Health, but a significant amount did. So that's some of the increase there. As well, on the right, you can see the total number of FTEs here, over 11,000. This is by far the most, the highest number of any division that you'll see in the Department of Health and Human Services, and the reason is the facilities, the state-operated healthcare facilities, and the staff that goes into operating 13 of those facilities. Administration kind of have put together over here is 220. I've included the vacancy rate here for you, 17% of administration. Division of Mental Health, 46 FTEs with around a 24% vacancy rate, but you can see the bulk of those FTEs are at the facilities, over 11,000. Also comes with a higher vacancy rate, around 29% recently. And we'll get more into the FTEs later on. I have a couple slides on those specifically. So looking at this current year's authorized budget, you'll recall it was $2.2 billion in planned expenditures. So this is 2 charts, 2 ways to look at that $2.2 billion. On the left is how the planned spending breaks down by category, and on the right are the funding sources and how that $2.2 billion, where that comes from. So in planned spending on the left, again, this is a little deviation of what you'll often see in DHHS divisions, and because usually we've called out the aid and public assistance is going to be the most significant chunk of spending, and that is significant here at 30%, but over on the far left, the largest category is personal services. Recall that this represents the salaries and benefits associated with the workforce. Again, that significant number of FTEs at the facilities is driving this number here. Also some funds coming from transfers, and I'll note the reserves at the bottom, $225 million. The bulk of that is non-recurring. A lot comes from the funding. In the prior presentation, we talked about the ARPA Temporary Savings Fund. So on a recurring basis, you wouldn't expect to see such a significant number in the reserves area. And on the right, the funding sources for these 2 divisions. The bulk come from 2 sources, federal receipts of almost $1 billion. There are some block grants here in the Division of Mental Health. There's the Community Mental Health Services block grant, the Substance Use Prevention, Treatment, and Recovery Services block grant. There's a state opioid response block grants, but the bulk of the federal receipts are really people that are eligible for Medicaid that are served in the state-operated healthcare facilities. The state is able to draw federal receipts on that. There's also over $840 million that comes from the net general fund appropriation, so significant appropriations here. So diving into that net general fund appropriation, so this is just that $848 million in net general fund. Sometimes I'll get the question, where do the state dollars go? Where are the state dollars being spent here? really fairly even between the facilities and DSOF and between kind of at a broad level what we call the community services in Division of Mental Health, with a small slice of 3% out for administration, costs of administration. So next I want to dive a little bit more briefly into the Division of Mental Health. Provides, as the name would imply, provides services for individuals who have serious mental illness, intellectual and developmental disabilities, or IDD, substance use disorders. There's also traumatic brain injury treatment here and some gambling addiction programs. But excluding DSOF and admin, as I've hinted at, we really kind of think of the services here generally as being the community services side, as opposed to the facility-based treatment in DSOF. And we often talk about the community services in context of the local management entities, managed care organizations, or the LME-MCOs. We discussed those a little bit in the Medicaid presentation last week. Not all of the community services go through the LME-MCOs, but a significant amount do. So I did want to touch on them in a moment. First, at a high level of the community services, we don't have time to go through all of the programs and all the services offered, unfortunately, but at a high level, there are prevention services mostly centered around substance use. A lot of those are funded through federal grants. The one I really wanted to call out was community and crisis services, and as you probably gleaned from what Director Crosbie talked about, that's been a significant focus in the last couple of years. Crisis services, people who may be having a behavioral health crisis often end up in settings that are maybe not appropriate for their needs at the time, maybe a hospital emergency room, sometimes a jail, and so there's been a lot of attention on these services recently, trying to find a way to get people more appropriate care in those settings. And as you've seen, some of that has come with investment in the form of dollars. There's also TBI specific services and supports. The last one often gets attention as we discuss the budget, single stream funding, and I'll show you why in a moment. This is funding for mental health, IDD, substance use, specifically for uninsured and underinsured people in North Carolina, and this entirely goes through the LME MCOs. And you can see on this chart of all the net general fund appropriations, all the state dollars that go through the Division of Mental Health, nearly 2/3 are for single stream funding. So that's why you'll hear this discussed a lot around budget time, is this is really where the bulk of the state dollars are in the community services realm, over $270 million for single stream funding. So we touched on the LME MCOs. Those are Alliance, Partners, Trillium, and VIA. So they manage services. There are some Medicaid enrollees still that receive services through there, most notably the tailored plans. We discussed those a little more in depth last week with Medicaid, so I won't rehash everything, but just as a reminder, that is the state's Medicaid population who have a serious mental illness or severe substance use disorders, IDD or TBI treatment needs. They also serve the Medicaid beneficiaries who are not enrolled in managed care. And the last bullet point is behavioral health, IDD, TBI services for the uninsured population, is really talking about single stream funding, as we referenced on the last slide. This is just a map of the catchment areas for the 4 LME MCOs. I know the county names are really small here, just to generally give you an idea of how that works. Each county is covered by one LME MCO. They have networks of local providers of the various services that we mentioned. They manage the care for people in their catchment areas. I wanted to take a moment and talk about Transitions to Community Living Initiative, kind of a disclaimer. This isn't entirely housed under the Division of Mental Health per se. It's kind of a cross-division effort. But because we're talking about behavioral health today, I thought this was the appropriate time to mention it. What Transitions to Community Living Initiative, or TCLI, is addressing is, we'll step back and look at the Olmstead Act. That is a federal Supreme Court decision, says that people with disabilities should be allowed to receive community-based services rather than necessarily going to institutions. And in 2012, after an assertion that the state was violating the Olmstead Act, the state entered into a settlement agreement with the U.S. Department of Justice. that included some milestones, some including numbers of people that had to be served by certain dates. There are a lot of milestones included in this settlement agreement. The most notable, at least in terms of when we look at from a budget perspective or of maybe hard numbers, are usually in the supported housing space, employment supports, or community-based mental health services. All of the milestones with the idea of ensuring that people are able to receive treatment and care and able to live in the community if they choose to. The latest modification to the settlement agreement, any outstanding unmet provisions need to be met by July 1st, 2027, which is the end of the upcoming fiscal biennium, so just over 2 years away. So TCLI, that is how the state is complying with this DOJ settlement agreement. So it is within DHHS. It'll go across a number of divisions, Division of Mental Health, Central Management and Support, a little bit in Aging and Adult Services, as well as the state's Medicaid program in DHB. The total budget, just over $80 million, or at least from general funds, I should note that. $23 million comes from the Division of Mental Health budget. So not necessarily the largest chunk if you think back to the numbers we're talking about for the Division of Mental Health, but I wanted to mention this because the last couple bienniums has come up, funding has been provided as the state moves towards trying to meet a lot of these milestones. So sometimes this gets discussed in the long session in the budget process, so I wanted to note this here. Next, we'll move on to DSOF, or the Division of State-Operated Healthcare Facilities. These facilities treat individuals who have serious mental illness, IDD needs, substance use disorders. There are 13 facilities across the state with over 11,000 FTEs budgeted. They're broken down into a couple of different categories, different types of facilities. So I have information on each of them. Because of the time today, we won't talk about each facility individually necessarily, but I do have information on each of these slides. But I'll try to go through it at a high level fairly quickly. So the first type are psychiatric hospitals. You can see here that there are 3 psychiatric hospitals, loosely speaking, in the East, West, and Central region that each cover specific counties, but there are some units that serve statewide. So forensic patients, for example, at Central Regional, that's people who have been deemed incapable to proceed through their cases. In the justice system, or found staffed, which is something we'll address after this. But you can see on the map where these are located here. The next type to discuss are the ADACs, the Alcohol and Drug Abuse Treatment Centers. 2 of these facilities, and as you would imagine from the name, they are providing substance use disorder treatment to individuals who specifically have chronic mental problems and have significant treatment needs. Here's some key statistics. You can see these facilities are smaller than the hospitals are, and looking at the median length of stay, not necessarily quite as long of a treatment time, typically shorter. The next category are the developmental centers. These are 3 of these across the state. These are for individuals with intellectual or IDD. My mind is blanking on the acronym, so I'm going to jump back to the acronyms. But the point I wanted to make here is that these meet the ICF-IID, so Intermediate Care Facilities, individuals with intellectual disabilities, levels of care, which is a CMS, Medicaid, Medicare level of care provided, and for whom community-based services haven't really been available or appropriate. And again, looking at the key statistics here, you can tell that the developmental centers are larger facilities serving a higher number of people, and we'll touch on this in the FTE discussion that a lot of the FTEs are working at either at the psychiatric hospitals or the developmental centers. Neuromedical treatment centers is the next category, again 3 statewide, and the level of care provided here is specialized skilled nursing facilities, SNF level of care. And looking at the key statistics and the map here for these facilities, 3 across the state. Last category, residential programs for children. There are 2 here rather than serving regions of the state. These 2 facilities provide statewide programs for different ages. So Whitaker in Granville County is serving teenagers, and the Wright School in Durham, children age 6 to 12. These are residential schools for children and adolescents. And again, looking at the key statistics, smaller facilities than some of the others, serving a specific population. So in the discussion on the facilities, I wanted to move on and dwell for a few minutes on the FTEs, the workforce for these facilities. So over 11,000, you can see here by category type, as I mentioned, almost 80% are at the psychiatric hospitals or developmental centers. Lower numbers, but still significant numbers of FTEs at the neuromedical centers, the ADACs, and at the 2 residential programs for children. We saw the vacancy rate in an earlier slide around 29% for the facilities. So looking at that historically, for raw numbers, we've typically seen around 2017 to 2021, maybe 1,100, 1,200, 1,300 vacancies per year. You can see that increasing really significantly in 2022. And I'll note these are point in time numbers. These aren't averages for the entire year. This is one point in time pulled, but just to give you a high level idea, went up to around 2,800 vacancies in 2022 and all the way up to almost 3,700 in 2023. So the number of vacancies decreasing a little bit, but still significantly higher than historical levels. And so this is especially key, as we mentioned on the key statistics slide. The capacity of the facilities is if they're fully staffed. If they're not fully staffed, that means that there are fewer people able to be served. Fewer people are working, so you have beds that are not available, or sometimes entire wings that are not available. So that's really the consequence here. The challenges, so why are there vacant positions at DSOF? There are a number of reasons here. The first, I should have called this out, sorry, on the prior slide. So in 2022, you'll recall, if you think back to the kind of the shocks and changes to the labor market during the COVID-19 pandemic, I think that was really what we saw drive this. So this was, even outside of healthcare, we saw big changes in labor market and the cost of labor. But specifically for DSOF, some of the challenges are salaries versus the competitors who they're competing, especially for hiring things like nurses, healthcare techs. Often in government jobs, you're competing with other levels of government, maybe federal government, local government. DSOF facilities are typically competing with private sector for staff for these facilities. So another area is flexibility and maybe incentives that they can provide during the recruiting process. The general workforce shortage for healthcare workers in general, which is not just a DSOF challenge or really just a North Carolina challenge. This is something we see wider. The high acuity challenging patients that FTEs positions at the DSOF facilities do in their day-to-day job. So you can see really at a high level, there's a number of challenges here. One strategy that may be coming soon, we just received the base budget for the upcoming year, and it does look like this strategy is maybe starting to be undertaken by DHHS to the tune of a few hundred positions. This is to look at some of the long-term vacant FTEs and consider eliminating them and kind of concentrating those resources, reallocating the funds towards the existing FTEs with the hopes of improving the retention rates for the positions that are filled and the recruiting abilities for the positions that are not filled. This is not something that you'll see the effects immediately. This is a little bit longer term before you see things happen. I just wanted to call that out as a potential strategy. It looks like DHHS is starting to undertake on some level. Next, looking at the opioid settlement funds that the state is receiving. So kind of a similar caveat to TCLI, the opioid settlement funds are not necessarily under the strict responsibility of the Division of Mental Health, but topically they fit today, so I wanted to mention them during this presentation. Between 2021 and 2039, North Carolina expects to receive almost $250 million from various opioid settlements. And so the big note here is this is the state share. This is what the General Assembly has responsibility over. So you may be thinking you've heard much higher numbers for the state. Most of the funds are going to counties and municipalities. So this does not include the funds that are going to the counties. The counties have the authority to decide where those funds are going. Today, I'm only talking about the General Assembly's portion, the state share. The settlement funds go directly into the opioid abatement reserve, and like I mentioned, they're not really managed by an agency. They have to have an appropriation by the General Assembly to be spent or acted on. Largely, or high level speaking, the settlement agreements say that the funds may be used for opioid remediation activities, which is a pretty broad term, but there's a pretty exhaustive list of examples, approved strategies in the settlement agreements that they encourage recipients of the funds to do. Most settlements are generally front-loaded, so just in terms of the funding, by the end of the upcoming fiscal biennium, the state will have received over half of the state share, even though there are funds coming until 2039 because the funds you receive higher amounts in the first few years of these settlements. Thus far, North Carolina has appropriated $50.5 million of the state share. Again, because of time, I won't go through and read each of these. The one thing I would point out is often I get questions from members on what is my county doing with their funds, or how much is my county going to receive. The core NC data dashboard under the collaboratory bullet point here, that's typically where I go to answer these questions for you. This is the best resource I know of to find out how much funds each county is going to get. They have contracts there that your county has entered into, spending plans, so a pretty robust data on that website. So if you're interested in what your county is doing or planning to do with those funds, that's a great place to start. Again, speaking just of the state share, not the county funds, just to give you an idea of how the schedule looks for the expected funding to be received. So first on the left, June 30th of this year, so the end of the current fiscal year, we expect to have $43.8 million available in the reserve unappropriated. And on the right, you can see the future year schedule. I've put a border around the first 2 years. That's the upcoming fiscal biennium. 17 million in the first year, 13.5 in the second year. So you add those numbers together, you can see that there is over $70 million available to be appropriated in the upcoming fiscal biennium from opioid settlement funds for the state share. Next, looking at the significant budget actions in this space from the current fiscal biennium, 23-25. So the bulk of them coming in the 2023 Appropriations Act, and I'm going to go over this fairly quickly because you can see the bulk of the funds for the Division of Mental Health and DSOF, almost $300 million came from the ARPA Temporary Savings Fund. We just had a presentation on the spending and how those funds are doing, but for behavioral health in the last biennium, this is really kind of where the bulk of the funding has gone towards, and I've named a couple of the largest buckets here that specifically went to Division of Mental Health, the justice-involved population that was mentioned, crisis system improvements, and I also wanted to call out the DSOF workforce stabilization efforts because we discussed the vacancy rates at the facilities. Those aren't the only items, but those are the biggest ones that went through Division of Mental Health. You can also see funding for TCLI, which we discussed. Some of the opioid settlement funds were spent, and finally the at the very bottom in fall 2024, 25 million was spent or was allocated for mental health and IDD in the wake of Hurricane Helene. And the last point here, just to touch on briefly, potential budget considerations, really decision points or topics that you may hear come up here in the long session. The first TCLI, recall that's the settlement agreement with the U.S. Department of Justice. There are some outstanding provisions the state is required to comply with by July 1st, 2027, and we do anticipate requests for funding to come through on that. Second is the opioid settlement funds. As I just acknowledged, over $70 million is available for the state share to appropriate if General Assembly chooses to. And last, this is really, rather than like a funding need, this is really an ongoing thing to continue monitoring really the topic of the presentation we just had, how those efforts are going. Are there things that are especially successful the General Assembly wants to look closer at, and really just seeing how that's going. As was mentioned here, this is more of a longer term project. The funds, because of the nature of the funding source, the funds don't go out right away, and they take time to plan, they take time to be spent. So maybe something we'll be continuing to do later on in this biennium and in next biennium, but just wanted to mention that. And Mr. Chair, that's the end of my presentation.
All right, thanks, Luke. So you gave a few minutes left for Susie to wrap up, and then we do have, there's another committee in here afterwards, so we do have to adjourn at 10 minutes till. So hopefully we'll have 10 or 15 minutes for the committee to ask questions. So everybody gets one, think of it quick. So go ahead, Susie.
Thank you, Mr. Chair. Good morning, chairs and members. So I had a feeling we might be in a bit of a time crunch by the time we got to DCFW. So this is a fairly high-level overview of the newest division under the department. And I will be moving through the slides fairly quickly to stay on time. So here's a familiar roadmap that most of our presentations have been following something along these lines. We'll start with their authorizing laws and responsibilities. The Division of Family and Child Wellbeing was established internally by the department in 2022 with the purpose of coordinating existing programs and staff coming from the divisions of Public Health, Social Services, and Mental Health in order to address the health and well-being of children and their families. The division is organized into 4 primary sections. This slide gives a high-level overview of the functions and programs within those sections, which includes food and nutrition services, community nutrition programs, the early intervention program, and the whole child health section. And I will be covering these in slightly more detail a little later in the presentation. Again, this is not an exhaustive list of authorizing laws and responsibilities, but here are a few statutes that govern some of the key programs currently administered by DCFW, including food and nutrition services and then the early intervention program. We'll take a look at DCFW's budget over the next few slides. This slide might look a little bit different than the others from the other divisions because, as I mentioned earlier, this is the newest division within the department, and there's only a short history to show here. The first year's budget is a little wonky because the departmental restructuring was still a work in progress at that time. But you can see that division is mostly receipt supported, much like other divisions within the department. And most of those are through federal funds, in particular for the community nutrition programs, for FNS, and for receipts for the EIP, early intervention program. Again, unsurprisingly, if we take a look at requirements by purpose, most of their budget also goes toward aid and public assistance at 81%. And the next largest chunk goes towards personal services. They currently have an 11% vacancy rate, which is below the department as a whole and also below the statewide average of about 19%. Looking at total requirements by each of the 4 sections within the division, we can see that the community nutrition programs make up about 70% of the division's budget, followed by the early intervention program and then the whole child health section. Food and nutrition services does come in as the smallest in terms of requirements, but I will note that a large portion of this division's budget still remains within the Division of Social Services, which my colleague will talk about in another meeting. And when the FNS program was transferred to DCFW from DSS, some of the staff and administration funding remained in DSS, mainly dealing with the EBT call center and some staff that perform continuous quality improvement and monitoring of the counties. So that's all to say that that is not the entirety of the FNS budget. That's the portion that's in DCFW. If we look at their budget without taking the receipts into consideration and we focus just on the net general fund appropriation, the whole child health section and the early intervention program collectively make up about 90% of the division's net general fund appropriation. Next, we will talk about each of the sections and some of the programs, again at a fairly high level in the interest of time. We can start with food and nutrition services, which is the state's version of the federal supplemental nutrition assistance program, known as SNAP, or sometimes referred to as food stamps. This is a federally funded entitlement program and is operated primarily by county departments of social services with oversight from the state through the Division of Child and Family Wellbeing. Eligibility for this program is determined by many factors, including income, household size, as well as assets. And the table on the slide shows the typical maximum monthly income amounts for varying household sizes, along with the maximum monthly benefit amount. And I will note that most recipients do not receive the maximum monthly benefit amount that is shown on the screen. This slide shows average monthly participation rates for the past 5 federal fiscal years. Unsurprisingly, participation did increase during the COVID pandemic years, but has started to come back down with a monthly average of just over 1.4 million participants from around 700,000 households in federal fiscal year 2023-24. And you can see on the right that the average monthly benefit is lower than the maximums that we saw on the prior slide at just under $350 last year, with total benefits distributed across the state at just under $3 billion. So the division also administers the summer EBT program, which is known as Sunbucks, and this is a new federal program that provides benefits to low-income families with school-age children when schools are closed during the summer months. Last summer, $130 million in assistance was provided to over 1 million children, with each receiving $120 in benefits for the summer months to purchase food at participating retail grocers. The next section covers the 2 federal community nutrition programs that the division administers. Special Supplemental Nutrition Program for Women, Infants, and Children, known as the WIC program, provides nutrition, education, and other supports to low-income pregnant and postpartum women, infant, and children up to age 5. It is locally operated by county departments of social services with oversight from the department, with about 250,000 participants in the state each month. The second program is the Child and Adult Care Food Program, which provides reimbursements for meals served to eligible children and adults who attend qualifying non-residential care facilities, with about 57 million meals and snacks reimbursed in 2024. The next program we will cover is the Early Intervention Program, also under the division, and this program complies with Part C of the Federal Individuals with Disabilities Education Act by providing support and services for families and children birth to age 3 who have special needs. There are 16 children's developmental service agencies across the state that provide service coordination, evaluation, and assessments. Treatments are provided through contracted service providers or the state as provider of last resort. And there are many different types of treatments, but they may include speech therapy, physical therapy, vision services, nutrition services, or audiology services. Funding for the services is provided by a mix of federal grants, Medicaid payments, private insurance, private pay, along with the state general fund dollars. This chart shows the number of children enrolled in the EIP program for each fiscal year. And there is a noticeable dip in enrollment during the COVID-19 pandemic when people in general were receiving fewer healthcare and other treatment services, but participation has been inching back up to pre-pandemic levels since then. This is a map that shows the 16 Children's Developmental Services agencies, sorry, that's a mouthful, across the state, 14 of which are comprised of state employees and 2 of which are contracted organizations. And the final section I'll touch on is the whole child health section, which is comprised of various programs that address physical and behavioral health needs from birth and through the course of childhood. In the interest of time, this is going to be a very high level overview. There are many more programs than listed on this slide that this division administers. The Child Behavioral Health Unit works with family organizations, child serving agencies, universities, and Medicaid payers to understand and address gaps in child behavioral health needs and services through pilot projects, policy changes, and workforce development initiatives. The School, Adolescent, and Child Health Unit supports whole child health with a focus in schools, school health centers, and child health and care management programs in local health departments and community settings. The Child and Family Wellness Unit supports the health and safety of children through evidence-based practices by implementing programs that focus on the health and well-being of young children in particular and their families. And the Best Practices Unit provides leadership training, consultation, technical and data assistance to the public to assure that children receive health and related services that are evidence-based, consistent with current practice standards, and with an emphasis on children and youth with special healthcare needs. And then finally, there's also the Genetics and Newborn Screening Unit under this section, which provides population-based services for newborn hearing screening and follow-up, newborn blood spot screening and follow-up, speech and hearing disorders, and genetic conditions through training, education, consultation, technical assistance, and direct services. And I will conclude with some recent legislative actions. The Second Recovery Act for Hurricane Helene, Session Law 2024-53, appropriated $10 million from the Hurricane Helene Fund for the Disaster Supplemental Nutrition Assistance Program, known as DSNAP, for the state and local administrative matching funds in response to Hurricane Helene. Approximately $45.4 million in federal benefits was distributed to 183,000 recipients and 73,000 households across the state, across the western part of the state, with an additional $24 million in federal funds for traditional FNS benefits replaced for over 200,000 recipients impacted by Hurricane Helene. And of course, as we just heard from the department, there is a sizable investment from those ARPA temporary savings funds that the department is also administering for the behavioral health of children. And with that, Mr. Chair, I hope I came in under time and happy to stand for questions.
That was great. Thank you very much for that. I know that all 3 presentations were very good, and I'm sure they were so comprehensive there is no questions for the committee, but let's take a chance. Chair White, question? And I'll let folks have one question, and if we don't get to the committee, I'm sure the folks will be happy to answer.
One question.
One question. And half of a follow-up.
Which one I need to ask first. Let's see. Let me ask this, because I think this will sum it all up. Secretary Osborne, Deputy Secretary Osborne, I think I got a lot of my questions answered through the presentation by Mr. MacDonald, but with the $40 million that we had to, that you referenced, that for staffing shortages at the facilities, basically the neuromedical centers and the developmental centers, I'm assuming that's what you were referencing. Obviously there is a real issue of safety for those employees, and that is one of the main reasons that they've shared with me that they are leaving, especially when Deputy Director Crosbie said that you all are targeting on less restrictive facilities for the patient, for the clients. But have you used or thought of, or can you use any of this $40 million to actually have not police officers, but security folks that can be in those areas where these nurses and technicians are working every day? Because that is one of the major reasons that we're losing, and we are bleeding employees in the state, and obviously with issues that have just affected their health insurance or could affect their health insurance, we're going to bleed a lot more, and I don't know what we're going to do when they're gone.
Deputy Secretary.
I know that's a huge question, but we need to address that.
I'll let someone from the department respond to that.
Hi, this is Acting Deputy Secretary Karen Burkes. So yes, that is one of our concerns. We are implementing additional training for our staff so that we can better understand, so they can better have support our patients and our residents within our facilities. This is a concern. We are leaning on learning from others, what other systems are doing, so that we can implement this as well. But I don't know if Dr. Brown wants to add anything.
Dr. Brown?
Thank you, Chair. I think the only thing that I would add is that,
Please
Carrie, sorry,
identify
apologies.
yourself.
Carrie
That's all right.
Brown, Chief Psychiatrist, Department of Health and Human Services. The only thing that I would add is that this is part of the reason why we do not operate all of our beds, is because the safety of our staff and patients is paramount. And we recognize that because we are a safety net facility, we only accept individuals that have the most complex needs in the entire state, and therefore require very specialized care. And we continue to do things like try to leverage our whole DSOF as a healthcare system to be able to, when it's appropriate, move patients from one level of care to another or from one facility to another, to try to, because one of the primary tools is if you can separate a group of patients where there's a particular challenge, that can really make the environment much safer. And so we use a whole bunch of different tools to try to support our staff. We also have staff support teams at each of our state psychiatric hospitals that do have the ability to provide some psychological support for staff. And but we absolutely take the safety of our staff as well as our patients as of primary importance.
Thank you very much. Co-Chair Bergen?
Mr. Chairman, thank you. And I'll be real fast. I don't want anybody to answer this question or questions. I want you all to send data to everybody, because you know how I am. I pick a date, maybe last Friday.
Get your list ready.
Sir?
No, so get their list ready.
Okay. Yeah, get your list ready. I want to know, pick a date, maybe last Friday, how many people were involuntary committed in all of our hospitals, how many of them were children. Same thing with foster care. How many foster care kids and where were they at? How many were out of state? Somebody do a update on the Homestead Act on where we are. I want to know in a timeline where we are, because we want to be prepared when this thing is over. So on that, can somebody prepare something about EBT and SNAP benefits? Because my understanding is someone can walk in with an EBT card, and as long as something has a nutrition label on it, they can buy it. They could buy all of their EBT money in Red Bull if they wanted to. And I know we're talking about federal stuff and state stuff, but we just need to, if you could respond on that. And then there's a real troubling statement on page 13, and it says, launch staff training pilot with PRTFs to advance restraint-free crisis management. It's my understanding that we're sending kids to states where there is not restraint-free crisis management. And folks, we need to get a handle on that. If we don't do it here, we shouldn't allow it to be done somewhere else. So that's all. Thank you, sir.
Thank you very much. I will note that the clock in the back is a couple minutes fast, so we do have a few time for questions. Representative Cunningham, did you have a question? In spite of Representative Potts saying no.
Yes, thank you, Mr. Chair. I don't know if you all can collect the data, but what I'm looking at is the temporary staff that have to come in and fill the positions of the vacant slots in the state facilities. From what I understand, if a nurse is on temporary and she come in, she's doing about $3,000 a week to come up to Broughton or any of your facilities. If we are not retaining the staff, can we get the data to look at how much temporary staff you are using and that expenditure, and if the benefits, we have decreased the benefits. So most individuals that are employees are looking at benefits now. They need health care coverage. We need an analysis. We need data so we can look at what's actually going on in that space where we can retain nurses instead of paying temporary nurses. Can y'all do that for us?
Yes, we can
Thank
do
you.
that.
Did you need a response or?
I think they're going to have to collect the data and provide it to us.
right.
Thank you.
Representative Servania?
Thank you, Chair. I'd like to ask one of my many questions.
You get one.
I know. But first, I want to thank DHHS for coming here today and the work that they've done, especially in terms of reentry and mobile crisis. But, and EPIC, that was amazing. But it's been my many-year concern about kids in our offices and EDs. Thank you for bringing it down from 33 to 22. But 22 is still too much. So what do we need to do to help you all get that to zero? Because this is implications on the county, our LME MCOs, us. What do we need to do to help get that to zero?
Thank you for that question. Susan Osborne, DHHS. So you are helping. We are building that continuum. We have to start upstream. Many of the evidence-based practices, many of the initiatives that we are investing in will go upstream and work with families before we get to the point that children enter the foster care system or just need a higher level of care and end up in our emergency rooms. So the investments, we need, and we have to work cross-divisionally. No one system, no one agency can meet this need. The recent investment in the Child and Family Specialty Plan is another tool to help us with this. The kinship funding that you provided is another tool. As we keep children in their families, research shows us that they have better school outcomes and behavioral health outcomes. So it is to continue to invest and support this continuum of the child serving system. It's been impacted by the workforce. It's been impacted by COVID and the increased mental health needs of children.
I have follow-up.
All right. Now, we got
Never mind.
last question, Representative Allman, and then we'll be done.
Thank you, Mr. Chairman. I was just curious about the $71 million under the adjustment and involvement investments for supporting individuals reentering the community. I was just looking to get maybe a breakdown of what some of those programs are in more detail. That doesn't have to be right now, you know.
We are happy to do that, sir. Thank you.
All right. Thank you very much for the team of both Fiscal Research and the department for being here. This committee is adjourned.